Hello, my name's Josiah McCain. I'm a gastroenterology fellow at Mayo Clinic in Arizona. On behalf of my co-authors and myself, I'd like to thank Gastrointestinal Endoscopy for giving me the opportunity to discuss our manuscript titled Creation of a Score to Predict Risk of High Conscious Sedation Requirements in Patients Undergoing Endoscopy. When evaluating a patient for elective endoscopy, providers must decide whether to proceed with conscious sedation or employ the services of trained anesthesia staff. The decision to utilize monitored anesthesia care, or MAC, is an easy one in the patient who is at high risk for sedation failure, has multiple comorbidities, or has not responded well to conscious sedation in the past. However, in patients who do not have an obvious contraindication to endoscopist-directed conscious sedation, the decision may be more difficult. Often these choices are based on previous experiences or clinical intuition. As a result, a portion of patients directed toward conscious sedation experience incomplete or aborted procedures. Failure to sedate a patient undergoing endoscopic procedure is frustrating, not only for the patient, but for the endoscopist as well. It may also expose the patient to undue risk of adverse effects of medications or repeated procedures, which negatively impact both cost and patient satisfaction. The goal of our research was directed toward identifying independent, pre-endoscopy variables that might predict a patient's response to conscious sedation, with the hope that a quantification of those variables would help the provider decide whether or not that patient could be safely sedated without monitored anesthesia. We retrospectively reviewed all patients who underwent EGD, colonoscopy, or both using endoscopist-directed conscious sedation at Mayo Clinic, Florida, over a period of about 5 years. We then examined the documentation associated with those endoscopic procedures, looking for variables that could have led to conscious sedation failure. We identified patients who required higher than normal doses of sedatives or analgesics, patients who needed a reversal agent, patients who had an incomplete or aborted procedure, and patients who were in pain or uncomfortable for more than 75% of the procedure time. We identified 488 cases in which one of these inclusion criteria were met. We then matched each of those cases with 2 controls who met none of the inclusion criteria and were scoped by the same gastroenterologist. In comparing the 488 cases to the 976 controls, we identified 5 variables that distinguished the 2 groups from each other. Subsequently, we scored those variables based on the strength of their association with sedation failure and assigned a numerical value to those variables that allowed us to create a risk score that could be applied to all patients in the study and could predict with reasonable certainty whether or not a patient would have a high conscious sedation requirement. This table lists the 5 variables and numerical values assigned to them based on the strength of their associations with sedation failure. They are the age of the patient at the time of the procedure, the sex of the patient, the use of benzodiazepines, with the exception of clonazepam, which did not associate with high conscious sedation requirements, the use of opioids, and whether the patient underwent a single procedure or bidirectional endoscopy in the same sedation event. Each patient had a score based on age, with females receiving an additional half point, patients taking benzodiazepines excluding clonazepam an additional 1 point, those who used opioids an additional half point, and patients undergoing both EGD and colonoscopy another half point added to their score. The sum of these values for any given patient equates to their individualized risk score for sedation failure. In order to validate the score and its predictive capability, we retrospectively analyzed 250 cases that met our criteria and 250 corresponding controls from the Mayo Clinic in Rochester, Minnesota. In this validation study, we found that when compared to their retrospective controls, patients who had a pre-endoscopy risk score of 3.5 or greater had a 30 times greater probability of sedation failure. We believe the score could be used as an adjunct for the standard pre-endoscopy patient evaluation. Its simplified nature means that any provider, whether endoscopist or not, could assign a patient a score that would help decide whether conscious sedation is appropriate. We understand that in many cases a score is not necessary to direct a patient toward MAC and away from conscious sedation. However, patients who do not have an obvious contraindication for conscious sedation may benefit from it. Thank you for your time and your interest in our research.